Good afternoon, everybody. My name is Samantha Holton, and today we'll be going over the Ventilator-associated Events Surveillance Guidelines and Protocol Application for 2025. My colleague Emily Witt will be moderating the Q&A feature, as well as the ServiceNow portal to answer any questions that you may have throughout the presentation. And these are our learning objectives for today. So by the end of today's presentation, you should be able to explain VAE key terms, describe the VAE surveillance algorithm, explain the criteria for meeting each tier in the VAE algorithm, and locate resources for VAE surveillance and reporting. And all of this is based on information that can be found in Chapter 10 of the NHSN Manual. In the following slides, we'll be going over some resources to aid in your VAE surveillance. So where can you find VAE surveillance guidance? On NHSN's webpage, you can navigate to your facility type, and from there you can select the patient safety component and then select VAE under patient safety component modules. On the VAE webpage, you'll find hyperlinks for the protocol, the VAE calculator, and the VAE FAQ page, among some other resources as well. In addition to the VAE calculator, NHSN also provides worksheets to help you make VAE determinations, including the VAE data collection worksheet and the VAE antimicrobial worksheet. But let's talk some more about the VAE calculator. The VAE calculator is designed to help users learn how the VAE surveillance algorithm works and assists in making VAE determinations. The calculator does not store any data that you enter because it is run locally on your computer, and it will not report any entered data or VAE determinations to NHSN. With that being said, experiment with it by putting in some test scenarios to see what happens. The VAE calculator operates based on the VAE algorithm. Whenever you have entered your data and received a determination, you can click on the Explain button in the calculator, and an explanation as to how the determination was reached will pop up. While the VAE calculator is a great tool, it does have its limitations. So remember that the correct determination by the calculator is wholly dependent on the correct data being entered. It is not a substitute for you knowing and understanding the rules for entering values in the designated fields. And another one of the VAE tools that NHSN provides is the VAE data collection worksheet. Here you can fill out applicable data to come to a VAE determination based on the VAE algorithm. And this is an example of what the VAE worksheet filled out will look like. After you have filled out all applicable information, the worksheet helps to visualize which VAE criteria are met and may assist with final VAE determination. All right, now let's get into the details of VAE surveillance. But first we need to go over some key terms. So what is a ventilator? A ventilator is a device used to support, assist, or control respiration through the application of positive pressure to the airway when delivered via an artificial airway, specifically oral or nasal endotracheal or tracheostomy tube. Please note that ventilation and lung expansion devices that deliver positive pressure to the airway, such as CPAP, BiPAP, etc., via non-invasive means, for example by nasal prongs or full face mask, are not considered ventilators unless the positive pressure is delivered via an artificial airway. A ventilator-associated event is an adverse event that's associated with the use of a mechanical ventilator. There are many different possible etiologies for a VAE, including infection, fluid overload, acute respiratory distress syndrome, atelectasis, or even provider preference in adjusting ventilator settings. Remember that surveillance is information for action. You may find that there are issues associated with VAE detection that need to be addressed. VAEs are identified using a combination of objective criteria, including deterioration in respiratory status after a period of stability or improvement on the ventilator, evidence of infection or inflammation, and laboratory evidence of respiratory infection. These are categorized into 3 tiers: ventilator-associated condition, infection-related ventilator-associated complication, and possible ventilator-associated pneumonia. And in the next couple of slides, we'll go into why we perform VAE surveillance. A 2015 CDC point prevalence survey determined that pneumonia was the most common HAI identified in the sample. 35% of those pneumonias were found to be ventilator-associated. And while ventilator-associated pneumonia, or VAP, is an important complication of mechanical ventilation, there are other adverse events that can also occur in ventilated patients. Surveillance for ventilator-associated events used to be limited to VAP, but there can be issues with subjectivity when interpreting radiographic findings when applying this definition. So there was a need for a more objective surveillance definition to capture these types of events. Some of the goals for the VAE definition when it was being developed were to focus on objectivity, reliability, and the ability to automate, as well as identify a broad range of conditions and complications occurring in mechanically ventilated adult patients that may be preventable. The VAE definition is also meant to enhance the ability to use surveillance data to drive improvements in patient care and safety. I would like to briefly go over some key differences between VAE and pneumonia NHSN definitions, which Jennifer will be going over later this afternoon. VAP is ventilator-associated pneumonia, and it's a pneumonia definition, whereas PVAP is a possible ventilator-associated pneumonia, which is part of the VAE definition. VAP is more limited in scope as it only identifies ventilator-associated pneumonia compared to VAE, which is designed to detect more events associated with mechanical ventilation. And next, we'll be talking about the inclusion criteria for VAE surveillance. The settings for which VAE surveillance are performed are for inpatients of acute care hospitals, long-term acute care hospitals, and inpatient rehabilitation facilities. VAE surveillance is location-based. Only patients in adult locations are eligible for VAE surveillance, regardless of the patient's age. So pediatric patients in adult locations would be included in VAE surveillance. While pediatric patients in adult locations are included in VAE surveillance, it is not recommended to include young children who are not physiologically similar to the location's adult patient population in VAE surveillance, and NHSN encourages utilizing a virtual location in these situations. Additionally, patients must be receiving mechanical ventilation support for more than 2 calendar days to be eligible for VAE surveillance. There are certain modes of mechanical ventilation included in VAE surveillance. Patients who are receiving a conventional mode of mechanical ventilation while in the prone position and while receiving nitric oxide therapy, helium oxygen mixtures, or epiprostenol therapy are all included in VAE surveillance. Airway pressure release ventilation, or APRV, and related modes are included as well. So who's excluded from VAE surveillance? Patients on high-frequency ventilation, paracorporeal membrane oxygenation, or extracorporeal life support are excluded from VAE surveillance during the time that they are receiving those therapies. Additionally, patients in non-acute care locations, such as chronic care units, are also excluded from VAE surveillance. Since VAE surveillance is location-based, adult patients that may be housed in non-adult or pediatric locations are excluded as well. So there is a difference in who is eligible for surveillance and who is eligible to meet VAE criteria. Patients that meet inclusion criteria for VAE surveillance cannot meet VAE definition if they have been ventilated less than 3 days. The first 2 days of ventilation may be used to establish the baseline period of stability or improvement, but the earliest date of event for VAE is day 3 of mechanical ventilation. And I'll go into more detail regarding the date of event and baseline period of stability or improvement in the coming slides. Another key term I would like to introduce before we get into the VAE algorithm is episode of mechanical ventilation. An episode of mechanical ventilation is the period of days during which the patient was mechanically ventilated for some portion of each consecutive day. If there is a break in mechanical ventilation of at least 1 full calendar day, followed by reintubation and/or reinitiation of mechanical ventilation during the same hospitalization, a new episode of mechanical ventilation begins. And before we get into the algorithm, this slide serves as a reminder that the following NHSN Chapter 2 definitions do not apply to VAE surveillance. So that includes infection window period, date of event, present on admission, etc. None of these terms are applicable in VAE surveillance. So now we can begin our overview of the VAE algorithm, but please note that these are not clinical definitions and are not intended for use in the management of patients. The VAE algorithm is comprised of 3 tiers: ventilator-associated condition, or VAC, which is the respiratory status component; infection-related ventilator-associated complication, or IVAC, which is the infection or inflammation component; and possible ventilator-associated pneumonia, or PVAP, which is met when there is additional evidence of an infection of respiratory origin. The VAE algorithm is progressive in terms of criteria to be met, starting with VAC. This is not meant to imply that each subsequent tier is more clinically significant than the one before. It's just that there's additional evidence around the time of event that may help identify the potential cause. As I previously stated, all events begin with VAC, which is defined on the basis of respiratory deterioration. If IVAC is met, then there is additional evidence on whether the event may be infectious or non-infectious. If PVAP is met, there is additional evidence that the infection may be respiratory related. To meet IVAC, you must first meet VAC. To meet PVAP, you must first meet VAC and IVAC. The VAE identified is then reported at the highest tier of the algorithm that is met. Let's discuss the respiratory status component in greater detail. In order to meet VAC, the patient must be mechanically ventilated for at least 2 calendar days and have a baseline period of stability or improvement that is followed by a sustained period in worsening oxygenation. And this is how VAC criteria are met as it appears in the VAE algorithm. In order to meet VAC, there must be evidence of respiratory deterioration, which we'll define in the next few slides. For the purposes of VAE surveillance, respiratory status is monitored using 2 oxygenation parameters, FiO2 and PEEP. A patient's oxygenation needs can be addressed by adjusting the FiO2 and PEEP settings on the ventilator. FiO2 is the fraction of oxygen in inspired air. For example, the FiO2 of room air is 0.21, and thus the oxygen concentration of room air is 21%. Keep in mind that these values are equivalent. PEEP is positive end expiratory pressure, which is the alveolar pressure above atmospheric pressure at the end of exhalation. This is achieved by the introduction of mechanical impedance to exhalation and is expressed in centimeters of water. Now that we've defined FiO2 and PEEP, we can establish how to determine daily minimum FiO2 and PEEP. The daily minimum FiO2 is the lowest value of FiO2 during a calendar day that is set on the ventilator and is maintained for greater than 1 hour. Similarly, the daily minimum PEEP is the lowest PEEP during a calendar day that is set on the ventilator and maintained for greater than 1 hour. Note that for the purposes of VAE surveillance, daily minimum PEEP values between 0 and 5 centimeters of water are considered equivalent to 5 centimeters of water. Daily minimum values are determined using all eligible FiO2 and PEEP settings documented throughout a calendar day during times when the patient is receiving support from an eligible mode of mechanical ventilation in an inpatient location. Keep in mind that a calendar day is defined as midnight to 11:59 p.m. All conventional mechanical ventilation settings are to be used, including settings during weaning and mechanical ventilation liberation trials if the patient is receiving mechanical ventilation support during those trials, and conventional mechanical ventilation settings during times when a patient may be on an excluded mode of mechanical ventilation intermittently. Do not include settings from the emergency department or other pre-hospital or pre-inpatient locations. Ineligible FiO2 and PEEP settings include periods of time when the patient is on high-frequency ventilation, extracorporeal life support, or paracorporeal membrane oxygenation, as well as periods of time when the patient is not receiving mechanical ventilation support, such as during a TPEACE trial or a trach collar trial, where the patient continues to receive supplemental oxygen, but is receiving no additional support from the mechanical ventilator, or periods of time when the patient is being mechanically ventilated using APRV or a related mode. When using APRV or a related mode of mechanical ventilation, you only review FiO2 data as PEEP settings are not eligible for use. From the eligible documented settings, we can now determine the daily minimum FiO2 and PEEP. Use the lowest FiO2 and PEEP settings during the calendar day that were maintained for greater than 1 hour. If there isn't a value that has been maintained for greater than an hour, select the lowest value available regardless of the period of time in which the setting was maintained. There are a few situations in which this can happen. For instance, when ventilation is initiated late in the calendar day, such as 11:30 at night, and a PEEP of 5 was only maintained for 30 minutes before the next calendar day. The PEEP of 5 would still be your daily minimum PEEP, even though it wasn't maintained for more than 1 hour. Similarly, if ventilation is discontinued early in the day, such as 12:45 a.m., where the PEEP of 5 was only maintained for 45 minutes during the calendar day before extubation, your daily minimum PEEP would be 5. There are also instances when a patient's ventilator settings are very unstable throughout the day, and none are maintained for greater than an hour, so you would select the lowest FiO2 or PEEP value on that day. NHSN also provides guidance for when settings are recorded every hour or more frequently. In these situations, there must be sufficient documentation of consecutive recordings to meet the minimum required duration of greater than 1 hour. For instance, if settings are recorded every 30 minutes, there must be at least 3 consecutive recordings at that same setting. If documented every hour, 2 consecutive recordings at the same setting are needed. This helps provide standardization and daily minimum value determinations. When settings are recorded less frequently than an hour, for example, every 2 hours or every 4 hours, the daily minimum FiO2 and PEEP values are simply the lowest value set on the ventilator during a calendar day. Alrighty, let's take a look at this example, and I'm going to let you guys try to determine the daily minimum PEEP values and put your answers in the chat. So I'll give you just a few moments. All right, at first glance, you may notice that 0.5 is the lowest FiO2 value recorded during the calendar day at 3 o'clock. But since the next setting was recorded at 4 o'clock and increased to 0.8, the setting of 0.5 could not have been maintained for more than an hour. Therefore, 0.6 is the daily minimum FiO2 in this example because it was the next lowest FiO2 setting maintained for greater than 1 hour. 8 centimeters of water is the daily minimum PEEP because it is the lowest and only PEEP value recorded that calendar day. And here's an example of when mechanical ventilation is initiated late in the day on Wednesday. Take a moment and let us know in the chat what you think the daily minimum FiO2 and PEEP values are for Wednesday. All right, since no settings are maintained for greater than 1 hour on Wednesday, the daily minimum FiO2 is 0.6, and the daily minimum PEEP is 5 centimeters of water, since those are the lowest values recorded on Wednesday. All right, let's take a look at this example, and I'll let you all enter your determinations for the daily minimum PEEP and FiO2 values in the chat.
I'm seeing a lot of 0.6 over 5. I'm also seeing 5 over 0.6.
Perfect. All right. Since values are recorded every 4 hours in this scenario, you would select the lowest value in each parameter because you know that they've been maintained for at least 4 hours before the next recording. In this case, the daily minimum FiO2 is 0.6 and the daily minimum PEEP is 5 centimeters of water. So great work, everybody. Now that we have daily minimum values defined, we can move on to how they help establish the baseline period of stability or improvement. The baseline period of stability or improvement is defined by at least 2 calendar days of stable or decreasing daily minimum FiO2 or PEEP values and occurs over the 2 days immediately preceding the first day of increased daily minimum PEEP or FiO2. After the baseline period of stability or improvement, the patient has to have one of the following indicators of worsening oxygenation in the same parameter. So you can either have an increase in the daily minimum FiO2 of at least 20 points over the daily minimum FiO2 of the first day of the baseline period and sustained for at least 2 calendar days, or an increase in the daily minimum PEEP of at least 3 centimeters of water over the daily minimum PEEP of the first day in the baseline period and sustained for at least 2 calendar days. So let's put this all together to meet the VAC definition. First, you must use the daily minimum FiO2 and PEEP values to assess for a period of stability or improvement and also the period that indicates worsening oxygenation. Remember that stability or improvement and worsening are not identified by comparing FiO2 and PEEP values that occur during a calendar day, but by comparing the daily minimum values, from calendar day to calendar day. The baseline period and evidence of worsening oxygenation must occur in the same parameter, as each parameter is assessed independently of the other. The date of mechanical ventilation initiation is important as it helps set the time frame in which a VAE can occur. It is the actual date of mechanical ventilation initiation, not necessarily the date of admission to the facility. You can estimate the actual date of mechanical ventilation initiation if needed. If you don't know the actual date and an estimate of the actual date cannot be determined, the date of admission to the facility may be used as the date of mechanical ventilation initiation. When using the VAE calculator, you must begin by entering the date of mechanical ventilation initiation. Then you will enter all of the daily minimum values for the time period of interest. In this slide, you'll see an example of a baseline period of stability because the FiO2 of 30 was maintained for at least 2 days on mechanical ventilation days 3 and 4. Here's an example of a baseline period of improvement because the FiO2 went from 35 down to 30 over the 2-day period. In this example, you can see that there is a 2-day period of stability in both the PEEP and FiO2 parameters, with a PEEP of 5 centimeters of water and an FiO2 of 40 on mechanical ventilation days 3 and 4. Following the baseline period of stability is a 2-day period of worsening oxygenation, but only in the FiO2 parameter, with an FiO2 of 60 on mechanical ventilation days 5 and 6. There is also worsening in the PEEP parameter, but it does not meet the requirements to be considered a period of worsening oxygenation to meet VAC definition. All right, expanding on the example from the previous slide, you can see that VAC is met in the FiO2 parameter because there was a baseline period of stability in the FiO2 parameter, followed by an increase in the daily minimum FiO2 of 20 points over the daily minimum FiO2 of the first day in the baseline period. VAC is not met in the PEEP parameter in the same example because despite there being a 2-day period of stable daily minimum PEEP values, the increase in the daily minimum PEEP of at least 3 centimeters of water over the daily minimum PEEP of the first day in the baseline period is not sustained for at least 2 days. On mechanical ventilation day 6, the PEEP of 7 is only 2 centimeters of water over the first day of the baseline period on mechanical ventilation day 3. In this example, VAC is met in the FiO2 parameter. There is a baseline period of 2 calendar days of a stable daily minimum FiO2 of 40 on mechanical ventilation days 2 and 3, followed by an increase in the daily minimum FiO2 values of at least 20 points over the daily minimum FiO2 of the first day in the baseline period that is maintained for at least 2 days. Even though the daily minimum FiO2 went from 80 on mechanical ventilation day 4 to 60 on mechanical ventilation day 5, both values were at least a 20-point increase over the daily minimum FiO2 of 40 on the first day of the baseline period. The date of event for VAEs is defined as the date of onset of worsening oxygenation, or day 1 of the required 2-day period of worsening oxygenation following an at least 2-day period of stability or improvement on the ventilator. It's important to note that the date of event is not the date on which all VAE criteria are met, or the first day of the baseline period. The earliest date of event for VAE is mechanical ventilation day 3, so the first possible day that VAC criteria can be fulfilled is mechanical ventilation day 4. In this example, the VAE date of event is mechanical ventilation day 4. Since that is the first day of worsening oxygenation maintained for 2 days following a 2-day baseline period of stability. But why is the date of event important? First, it defines the VAE window period, which is the period during which criteria for other events, including IVAC and PVAP, must be met. The date of event also sets the VAE 14-day event period, where day 1 is the date of event. A new VAE cannot be reported until the 14-day event period has elapsed. For example, if April 1st is the date of onset of worsening oxygenation, or the date of event, and a VAC is reported, a second VAE cannot be detected or reported until April 15th. You also cannot upgrade a VAE based on data collected outside the VAE window period, but within the 14-day event period. Keep in mind that the 14-day event period is event date to event date. So a new baseline period of stability or improvement may occur during a previous event period. If you have a secondary BSI, the blood cultures must also be collected within the 14-day event period to be attributed to a VAE. The VAE window period is the period of days around the date of event within which other VAE criteria must be met. It is usually a 5-day period and includes the 2 days before, the day of, and the 2 days after the VAE date of event. Here you can see that the date of event is mechanical ventilation day 10, which is the first day of worsening oxygenation. The VAE window period starts on mechanical ventilation day 8, which is the first day of the baseline period of stability or improvement and continues through the 2 days after the date of event. To meet IVAC and PVAP criteria, all elements must occur within this shaded portion that represents the VAE window period. It's important to note that there is an exception in which the VAE window period is only 3 or 4 days versus the usual 5. Remember that a patient is not eligible to meet VAE criteria until mechanical ventilation day 3 or later. So in cases where the VAE date of event corresponds to mechanical ventilation day 3 or 4, the VAE window period may only be a 3 or 4 day window because it cannot include any days before the 3rd day of mechanical ventilation. For example, if the VAE date of event is mechanical ventilation day 3, then the window period includes only the date of event and the 2 days after, since the 2 days before the date of event are before the 3rd day of mechanical ventilation. If the date of event is mechanical ventilation day 4, the window period includes only the day before, the day of, and the 2 days after the date of event. In this scenario, the date of event is mechanical ventilation day 3, but mechanical ventilation days 1 and 2 cannot be included in the VAE window period. So the VAE window period is only 3 days, mechanical ventilation days 3 through 5. Here, the date of event is mechanical ventilation day 4, so the VAE window period is 4 days, mechanical ventilation days 3 through 6. The date of event is also important when determining location of attribution for a VAE. The location of attribution is the inpatient location where the patient was assigned on the VAE date of event. The transfer rule is applied when the VAE date of event is on the day of transfer or the day following transfer from one inpatient location to another in the same facility or to a new facility. The event would then need to be attributed to the transferring location. And you can find some transfer rule examples in VAE FAQ number 23 on the VAE webpage. All right, so now that we've reviewed the foundational elements to meet VAC criteria, we can move on to the infection-inflammation component, that is the infection-related ventilator-associated complication, or IVAC tier of the VAE algorithm. And these are the IVAC criteria as they appear in the VAE protocol. So once VAC is met, on or after calendar day 3 of mechanical ventilation and within 2 calendar days before or after the onset of worsening oxygenation, so within the VAE window period, the patient meets both of the following criteria to meet IVAC. First, an abnormal temperature or white blood cell count. Second, a new antimicrobial agent from the list of eligible agents in the appendix is started and continued for at least 4 qualifying antimicrobial days. And I'll go over both of these elements in greater detail over the next several slides. To meet the temperature or white blood cell count element of the IVAC definition, you must have an abnormal temperature of greater than 38 degrees Celsius or less than 36 degrees Celsius, or abnormal white blood cell count of greater than or equal to 12,000 cells per millimeter cubed, or less than or equal to 4,000 cells per millimeter cubed. These abnormal temperatures or white blood cell counts must be documented during the VAE window period to meet IVAC. This is regardless of whether there is an abnormal temperature or abnormal white blood cell count that is also present on admission or occurs outside the VAE window period. And here's an example using the VAE data collection worksheet. You can see that the date of event in dark gray is mechanical ventilation day 5, as that is the first day of the period of worsening oxygenation following a 2-day baseline period of stability. The VAE window period shaded in gray is mechanical ventilation days 3 through 7. Within the VAE window period, there are several instances of abnormal temperature and white blood cell counts that are highlighted. Keep in mind that only one instance of an abnormal temperature or white blood cell count is required to meet IVAC. The second element required to meet IVAC is that a new antimicrobial agent is started and continued for at least 4 qualifying antimicrobial days. A new antimicrobial agent is defined as any agent listed in the protocol appendix that is initiated on or after the 3rd calendar day of mechanical ventilation and within the VAE window period. What makes an agent new is if it was not administered to the patient on either of the 2 days preceding the current start date. The new agent must be administered intravascularly, intramuscularly, via the digestive tract, or via the respiratory tract. This new agent must then be continued for at least 4 qualifying antimicrobial days. A qualifying antimicrobial day, or QAD, is a day on which the patient was administered an antimicrobial agent that was determined to be new within the VAE window period. To meet the IVAC antimicrobial criterion, there must be 4 consecutive QADs. Days between administration of a new agent also count as QADs if there is no more than 1 calendar day between administrations of the same antimicrobial. There is no requirement that the same agent be given on the 4 QADs, and the QADs can occur outside the VAE window period as long as the agent is initiated within the window period. The date of initiation of antimicrobial agents is also important. When utilizing the VAE calculator, once a VAC has been determined, there are instructions to choose a drug from the drop-down list, and then you check all of the corresponding days that the agent was administered. As you can see from this screenshot, you have the capability to select dates before, during, and after the VAE window period. In this example, IVAC is not met as there are no QADs. Recall that in order for an antimicrobial agent to be considered new, It must be initiated on or after the third calendar day of mechanical ventilation and within the VAE window period. In this example, cefepime was initiated on mechanical ventilation day 2 and prior to the VAE window period, so it is not considered a new antimicrobial agent. Therefore, this event would remain a VAC. In this example, cefepime is initiated after the third calendar day of mechanical ventilation and within the VAE window period. Therefore, these administrations are considered QADs and are denoted as such on the right-hand side of the screen. Days between administrations of the same new antimicrobial agent also count as QADs, as long as there is a gap of no more than 1 calendar day between administrations of the same drug. In this example, cefepime is administered on mechanical ventilation days 4, 6, and 8, but not on mechanical ventilation days 5 and 7. But this still represents 5 QADs, including the days in between administrations. Here we have the administration of 2 different agents, cefepime and gentamicin. The requirement for 4 QADs can be met with multiple antimicrobial agents if each agent was determined to be new. Both cefepime and gentamicin were initiated after mechanical ventilation day 2 and within the VAE window period. And they add up to 4 QADs between the 2 agents. Therefore, in this example, IVAC is met. Days between administrations of different antimicrobial agents do not count as QADs. In this example, cefepime is administered on mechanical ventilation days 4 and 5, which are QADs, and then gentamicin is administered on mechanical ventilation days 7 through 9, which are also QADs. However, there is a gap on mechanical ventilation day 6 between the different agents. Mechanical ventilation day 6 does not count as a QAD, therefore the 4 consecutive QAD requirement is not met. And just a little bit more about IVAC and antimicrobial agents. Meeting the IVAC definition does not mean that the infection-related event is necessarily respiratory in origin. And the antimicrobial list was refined by removing select antimicrobial agents that would not be used or would be unlikely to be used and treating a lower respiratory infection in a critically ill patient. It's still possible that an existing agent may have dual purposes and not necessarily be treating a respiratory infection. Additionally, there's no need to discern the indication for the administration of the antimicrobial. Prophylaxis, de-escalation, change within class of antimicrobials, etc., are not exclusionary. All right, additional evidence of infection, including positive results of microbiologic testing, are used to meet PVAP. PVAP is the third and final tier of the VAE algorithm, which is made up of 3 criteria. Only 1 criterion is needed to meet the PVAP definition. PVAP criterion 1 is met with a positive culture of one of the following specimens when they meet quantitative or semi-quantitative thresholds, as outlined below and within the protocol, without the requirement for purulent respiratory secretions. The eligible specimen types include endotracheal aspirates, bronchoalveolar lavage, lung tissue, and protected specimen brush. Many labs report out culture results semi-quantitatively. So how do you relate your lab's semi-quantitative result reporting to the quantitative thresholds in the algorithm? First, you should ask your laboratory manager or director, as they may be able to provide you with guidance. But if they don't have this information, for the purposes of VAE surveillance, you may use semi-quantitative results of moderate, many, numerous, or heavy growth, or 2+, 3+, or 4+ growth. All of these meet PVAP criterion 1. And this information can also be found in FAQ number 20 in the VAE protocol. PVAP criterion 2 is met with purulent respiratory secretions, which are secretions from the lungs, bronchi, or trachea that contain greater than or equal to 25 neutrophils and less than or equal to 10 squamous epithelial cells per low power field, and a positive culture of one of the following specimens without sufficient growth to meet PVAP criterion 1. So sputum, endotracheal aspirate, bronchoalveolar lavage, lung tissue, and protected specimen brush. If your laboratory reports gram stain or direct examination results in a manner that does not quantify neutrophils and squamous epithelial cells as the definition is written, first check with the laboratory for direction and how to interpret your facility's reporting method. If your facility cannot provide guidance on how to correlate these results, refer to Table 2 in FAQ or FAQ number 15 in the VAE protocol. Table 2 within the VAE protocol provides instructions for using the purulent respiratory secretions criterion based on the lab reporting of respiratory secretion direct exam results. Some clinical labs use different reporting formats for respiratory secretion direct exam results, so this can be a helpful tool in those cases. And there are several tests that can be used to meet PVAP criterion 3. You may have an organism identified from pleural fluid when the specimen was obtained during thoracentesis or within 24 hours of chest tube placement. Positive lung histopathology, as defined below and in the protocol, may also be used. You may also use a positive diagnostic test for Legionella or a positive diagnostic test on the respiratory secretions for the following respiratory viruses to meet PVAP criterion 3. Remember, pathogens may be reported for PVAP events, but are not reported for VAC or IVAC. There are some pathogens excluded from PVAP reporting, including commensal flora of the oral cavity or upper respiratory tract. Additionally, Candida species or yeast not otherwise identified, coagulase-negative Staphylococcus species, and Enterococcus species are only available for use as PVAP pathogens when isolated from lung tissue or pleural fluid. In this example, a BAL specimen collected during the VAE window period results in growth of Staphylococcus aureus with greater than or equal to 10 to the 4th colony-forming units per milliliter. The BAL growth meets the specified threshold as defined in the protocol, and therefore PVAP criterion 1 is met. If the culture was reported semi-quantitatively, results of moderate, many, numerous, or heavy growth, or 2+, 3+, or 4+ growth of Staph aureus would also meet this criterion. Here we have a positive BAL culture with Staphylococcus aureus, but does not have a quantitative or semi-quantitative result. But since purulent respiratory secretions are also present, PVAP criterion 2 is met. To meet PVAP criterion 3, there must be a positive pleural fluid, lung histopathology, Legionella, or viral test result. Recall that Enterococcus species is an excluded organism except when identified from lung tissue or pleural fluid. Since Enterococcus was identified from pleural fluid in this example, PVAP criterion 3 is met. Secondary BSIs are not reported for VAC or IVAC, but they may be reported for PVAP when at least one eligible organism from the blood culture specimen matches an eligible organism from an appropriate respiratory tract specimen collected during the VAE window period. Secondary BSI may also be reported when the blood culture is collected within the VAE 14-day event period. Secondary BSI may not be reported for PVAP when PVAP is met with only the histopathology criterion and no culture or non-culture-based testing is performed on an eligible respiratory specimen, or a culture or non-culture-based testing of respiratory secretions, pleural fluid, or lung tissue is performed and does not identify an organism that matches an organism identified from blood. Additionally, excluded organisms identified from blood can only be secondary BSIs if PVAP is met with a matching organism in lung tissue or pleural fluid, even if identified in a blood specimen with an eligible organism that is secondary to PVAP. All right, that was a lot of information, but now that we've covered the VAE key terms and the algorithm, I'm going to go over some additional tips for VAE surveillance and reporting. Prior to performing VAE surveillance, it's important to familiarize yourself with the following VAE resources that we went over earlier in the presentation, including the VAE webpage, supporting materials, the VAE protocol, and the FAQs. I would like to also point out that while we do have some FAQs located at the end of the VAE protocol, we also have an FAQ webpage that goes into more detail of some VAE topics that we were not able to address in the protocol itself. When reporting VAEs in plan, meaning the VAE is selected in your facility's monthly reporting plan, you must report all events detected and at the highest level of the algorithm that is met. Be sure to assess patients for all events in the algorithm, VAC, IVAC, and PVAP. Remember that there is a hierarchy to the algorithm. If a patient meets VAC only, report the event as a VAC. If they meet VAC and IVAC, report only as an IVAC. Similarly, if VAC, IVAC, and PVAP are met, PVAP is the highest level of the algorithm met, so only PVAP is reported. The VAE event form and table of instructions are also available for review on the VAE webpage. The denominator data required for VAE reporting are ventilator days and patient days. These should be collected at the same time each day. Vent days are comprised of the number of patients in the chosen location who are on a mechanical ventilator at the time of the count. All patients, not just those eligible for VAE surveillance, are counted. So this includes patients on a ventilator for less than 3 days and those that are receiving excluded therapies. Patient days are the number of patients in the chosen location at the time of the count. And then the link at the bottom of the slide is for a table designed to assist in determining which patients to include in VAE surveillance and/or in daily counts of patients on invasive mechanical ventilation based on the type of mechanical ventilation or related treatments that they may be receiving. And here I have outlined some steps to aid in monitoring for a VAE. For every patient receiving mechanical ventilation, first determine the daily minimum values for both FiO2 and PEEP from the documented eligible vent settings. This is where the data collection worksheet comes in handy. For patients that meet VAC criteria, determine the date of event and set the VAE window period. Then, review the medical record for abnormal temperature and white blood cell counts within the VAE window period. If the abnormal temperature or white blood cell count element is met, Review the medical administration record for new antimicrobials and QADs. NHSN also provides an antimicrobial worksheet that may be helpful in this process. If a patient meets IVAC criteria, review laboratory results for specimens with collection dates during the VAE window period and determine if those results are from eligible specimens that meet a PVAP criterion. Oops, there we go. And it would be helpful for your VAE surveillance to establish relationships with both respiratory therapy and critical care colleagues. Share the protocol with them and discuss the collection of daily minimum values. Inquire about the frequency of use of certain excluded therapies and how to identify these patients. It's also important to have an understanding of your lab's approach to gram staining and culture result reporting. All right, this concludes my review of the VAE protocol and reporting instructions.